With similar passion, Stavya stands today helping thousands of patients lead a better life. The Spine series is an educational effort in the same direction. Today is the fourth webinar of the series for all of us. The topic for today is Deformity and Ankylosing Spondylitis. Ankylosing spondylitis creeps slowly. What starts as a minor back pain can lead to major complications if ignored. Sedentary lifestyle, improper diet, improper postures further adds challenges. This all eventually takes a toll on the spine health and adds fuel to the fire. As the challenges arise, so do the new possibilities. And today, to understand the same, we have an expert panel with us who shall be sharing their wealth of experience. Before we begin the program, let us all welcome our esteemed moderator for the day, Dr. Ravi Ranjan Rai. I also heartily welcome our chief guest for the day, that is Dr. Dilip Sengupta. Welcome Dr. Ravi Ranjan and Dr. Dilip Sengupta. Stavya literally stands for Lord Krishna, the first spine doctor in the world. He treated Kubja, a hunchbacked woman from Mathura. The legend says that Kubja was a hunchbacked woman who once crossed paths with Krishna in the lanes of Mathura. She offered him sandalwood paste. Overwhelmed with the devotion, Krishna pressed his foot on her toes and lifted her chin with 2 fingers. It is said, Kubja stood straight. The name Stavya has henceforth continued. With similar passion, Stavya stands today helping thousands of patients lead a better life. The Spine series is an educational effort in the same direction. Today is the fourth webinar of the series for all of us. The topic for today is Deformity and Ankylosing Spondylitis. Ankylosing spondylitis creeps slowly. What starts as a minor back pain can lead to major complications if ignored. Sedentary lifestyle, improper diet, improper postures further adds challenges. This all eventually takes a toll on the spine health and adds fuel to the fire. As the challenges arise, so do the new possibilities. And today, to understand the same, we have an expert panel with us who shall be sharing their wealth of experience. Before we begin the program, let us all welcome our esteemed moderator for the day, Dr. Ravi Ranjan Rai. I also heartily welcome our chief guest for the day, that is Dr. Dilip Sengupta. Welcome Dr. Ravi Ranjan and Dr. Dilip Sengupta. I now introduce our moderator for the day, Dr. Ravi Ranjan Rai. Dr. Ravi Ranjan Rai is a young, passionate and dynamic spine surgeon associated with Stavya. Dr. Ravi has been the winner of 2018 Global Outreach Program Scholarship. Dr. Ravi Ranjan has many fellowships to his name, such as the Minimal Invasive Spine Surgery Fellowship from France, the AO Spine Fellowship from Ganga Hospital, Coimbatore, and the FNB Spine Surgery Fellowship. Thank you and welcome Dr. Ravi Ranjan. I now hand over the session to him to kindly take us forward.
A very good evening to everyone. I am Dr. Ravi Ranjan Rai. On behalf of Stavya Spine Hospital, I welcome you all to today's webinar. I am glad to introduce our guest speaker for today, Dr. Dilip Sengupta sir, who would be joining us live from Texas, USA. We welcome you, sir. Dr. Sengupta sir has made an illustrious career in spine surgery, and he is presently the director of Center for Scoliosis and Advanced Spine Surgery in Texas, United States of America. He has immense experience and knowledge about complex spine surgeries, which he would be sharing with us today. Our webinar will begin with the discussion on spine deformities. What are the red flags in spine deformity, how to identify, and how timely treatment would change the outcome. Dr. Ajay Krishnan sir would be discussing all these questions in detail. The next part of today's webinar would be ankylosing spondylitis. Dr. Bharat Dave sir, Dr. Devanand sir, and Dr. Shivanand sir would be discussing about the main features of ankylosing spondylitis which every physician should know. Dr. Sen Gupta sir would share his experience regarding the surgical management of such cases. I would now request Dr. Ajay Krishnan sir to begin his talk.
Hello, everybody. So, among our web series talk of different topics, deformity is one of the topics which we are trying to cover today. And this is a very broad topic and very difficult to cover in a small time, but with an effort to make it very simplistic for understanding purpose and for making certain decisions. Let's go to the talk quickly. Now, natural curves of the spine is very well understood, and these are cervical, thoracic, and lumbar, and they develop from something which is in the worm as a C-shaped curve with held ordering developing a single further curve, and with the complete direct postures, you are having the primary and the secondary curves of the thoracic kyphosis and the lumbar cervical lordosis, and this remains with us for life. And with age as deteriorating on the age front, physical health, osteoporosis, these things again reverse and finally again goes back to this level probably. And in these natural curves, you have something as deviations, and which deviations are called scoliosis or a kyphosis with an incidence of 2 to 3 per 100, and at the same time an incidence of 1 per 1000. If you increase the number of the degenerative cases, the numbers would definitely shoot up. But these are the cases of the syndromic and the idiopathic cases which you have. Even a disc prolapse can give you a scoliosis, or say not actually scoliosis, it's actually a truncal shift, or it is a list which you are seeing. Many of the people mention it as scoliosis, but that is temporarily lived. At the same time, sagittal malalignments in high-grade spondylolisthesis like this, which is there, and that can also give you significant amount of deformities, compensated or decompensated. The spinal disorders presentations to us are usually pain and many a times neurological deficit. Very less cases of deformity per se, and the disability because of these three things are what they end up with us, and we have to treat them individually. And everybody knows, talks about and visits this leaning tower of Pisa, but from the day of its making, though it is famous, from the day of its making it had been sinking and tilting, and there has been a lot of efforts which has been put on the same side or the opposite side to reinforce and keep retaining it, so you can understand how what the body needs. And this is in the mythological stories of Indian context, where we have talked about Lord Krishna making a kubja straight, the first reference of a spine physician or surgeon or doctor, whatever you say. And what we are talking and why we are talking is that we are talking this because of purely cosmesis in usually all cases. And the other thing which occurs with imbalance and the loss of the normal efficient balance of the spine is more energy expenditure, and pain can ensue because of that. And vital organ compromise can occur if there is significant amount of kyphosis. Say any kyphosis which is more than 60 degree, 90 degree, they have significant effect on the pulmonary function, which gets manifested in the late ages. Neurological deficits are not routine, but it can occur in kyphosis, in syndromic cases, in degenerative cases. And the scoliosis de novo per se can lead to a early degenerative changes. These are the problems what we are thinking, which we can have at a later stage of life. And if we come to scoliosis, the reasons and causes can be basically divided into a congenital cause which is present at birth or during development, and it's neuromuscular scoliosis or myopathic scoliosis where there is abnormal balances of the neurological function between the muscle groups. There is an imbalance which can be because of cord dysfunction associated with a Arnold-Chiari malformation or cervical problem, or it can be purely because of other disorders like a myopathy, like any cerebral palsy, etc. So that is neuromuscular scoliosis. Degenerative scoliosis, which is in the adulthood, either it is occurring de novo and slowly occurring and getting progressed at a later age, or it is onset itself is in the later age because of the degenerative process. Then you have the most common thing which we are all fond of attending, treating, that is the idiopathic scoliosis, where you don't have any cause which you have identified. And there are four main types of it. One is present at the birth, one is juvenile, which is still the 9 years old, and then it's the 10 to 18 years where you call it as adolescent, and then you have the adult deformity scoliosis. The presentation of a idiopathic scoliosis is usually accidental, and there may be something which what else is getting investigated, or you have visited a doctor and the doctor spots, or an X-ray spots it, or there can be a manifesting hump of it which gets noticed, and you come into the medical attention. So the importance of any case of scoliosis, there always all the cases you have to have a history taking, but at the same time in scoliosis the purpose of taking of a history is to rule out the secondary forms of scoliosis which are more dangerous, because you are missing, then that can be unpredictable and that can go haywire. That's why you have to take history in that way. At the same time, history is to assess the present status of the growth and what is the growth progression expected. So that's why you need more history also. The presentations of congenital scoliosis can be prenatal diagnosis, can be diagnosis at birth, can be because of the skin stigmatas and associated congenital conditions. It has been brought to your notice, and hidden things can frequently be missed at the same time, like these hairs. These are indirect evidences of something drastic lying inside the spinal canal. At the same time, small dimple like this if brought to your notice, you have to explore, you have to see, you have to find out anything else is clinically evident or not, and investigation is needed for this. At the same time, as small as this spot, if there is no tuft of hair and you are seeing any lipoma or small bump in the lower sacral region which usually doesn't have any fat there, so you have to just think, scratch your brain key, you have to investigate. Basically you need to investigate, that is the most important thing. These are the neuropathic ulcers which may develop on the late time, but at the same time small things which are in the foot like this cavus deformities, or they say this toe clawing, or say calf wasting. These are the small things which may be there, suggestive of a secondary thing which is going on. At the same time, in congenital scoliosis, you may have high chances of other associated malformation to the tune of 60%, and for a mnemonic which we know, VACTRL, vertebral, anal, cardiovascular, tracheal, esophageal, renal, and limb malformations which can be there. Even nervous system malformations can be there. So we have to look out for other malformations also once you have noticed. So don't sit on it. You get it investigated. It is very important. It can be part of syndromes also, like Jaco-Levine syndromic association and type 1, type 2, wherein you see this type of X-ray picture itself. So there is a crowding of the vertebra which is there, and the ribs are apparent like a fan. So this is fan appearance. This is the typical appearance of a fan-like ribs. So this should bring you to this rare syndrome which is there, and you should think about it. Congenital curves. These are the curves which can be defined very well, not just on X-rays. You need CT scan for this. The reason is that there can be defects of formation, there can be defects of segmentation. Now, in these all defects of formation, these non-segmented ones or these incarcerated ones, they are likely to be benign, and even a semi-segmented may behave benignly. But a fully segmented one, which this hemivertebra is, that may completely be difficult to predict, and it can go on the progressive way. A wedge vertebra can also still save you, and it may neutralize over a period of time and may not progress on the right extreme corner, what I'm saying. At the same time, an unsegmented bar may progress, and it is likely to progress. It's not to may progress, it will progress. At the same time, this one with a hemivertebra, this is the most dangerous, which progresses like anything. So when you have identified these cases, you are able to predict the progression further. At the same time, a block vertebra, everybody knows it is going to remain like that, it is not going to progress. So you are not able to make these judgments about incarcerated vertebrae and the actual typifying of the classification till you have done a CT scan. So you need to get them at the age of 3 to 5 years, 8 years, so that you have some predictability of the curve and you can prognosticate things as to wherein you have to intervene. And a small surgery which can be done at say 3 years to 8 years can completely make it risk free, and something which can progress so badly to become an anaconda spine, and wherein you risk everything, the surgeon risks, the doctor risks. So that's why you need to investigate these patients early. And for the natural curves as well as other curves, the growth potential you have to know, and you should be knowing about the menarchal status, the breaking of voice, beard growth, the growth spurt. People rush to us when the menarche has already occurred, and you would be surprised that the actual growth velocity starts nearly a year before menarche. So don't sit on these things if it is brought to your notice. So you have to think about it, and you have to investigate what is the point of the growth of the patient. You should compare the patient's growth with their parents, and should predict that if there is more growth left, you have to maybe intervene early. So diagnostic workups needed, standard X-rays, whole length corrective MRI, corrective X-rays are needed. MRI is needed in many cases. CT scan for good number of cases needed. Radiographic curve assessment is basically on the curve angle. There are n number of parameters which is there. We will be deflecting away if we talk on those things and classification. So we will not be talking on that. But this is basically to evaluate the type of the curve, the pattern of the curve, and for planning of the surgery. So there are nearly 50 type of angles, measurements, distances which can be done. In nutshell, the cutoff is roughly 40 to 50 degree. Anything which has gone beyond 40 degree to 50 degree, it becomes cosmetically appearing. And once it is cosmetically appearing, and it is, you are able to see, the external person can see that it is there, something is there, and there is where it becomes significant, and that is clinical appearance. Some of the cases are only there which are on the lower side, or say 40 or 35, and they are very clinically apparent. Otherwise they are not clinically as apparent. That is the reason why this cutoff of 40 to 50 is kept. And we should know about the poor predictors of curve as syndromic, neuromuscular cases, and congenital, what we talked about, wherein the progression would be high, and therein we have to treat earlier. Lanston-Carlson nomogram is something which is of very great help, which can be kept in your OPD to say some progression about the curve. Say you calculate a curve angle, you calculate the riser, this goes to the chronological age, the chronological age dips to this, and this is what your prediction. So this predicts to your chances of progression. So higher the chances of progression, you should intervene earlier. So these are simple ways for idiopathic curves where it can be applied. But at the same time, if there is somebody who is coming to you, say at the age of 18 to 20 years, and now you want to know what else you want to need to do for this patient, then you can clearly say if it is a thoracolumbar curve or a lumbar curve, it's a curve which is greater than 30 degree, then only you have to think even ki that may progress. And basically only if the rotations are more than 30%, then they can progress. If there are translatory shifts, or the relationship of the last L5 vertebra, what is there, the tilt of those vertebrae predicts whether these curves will progress or not. Otherwise they remain nearly static, and they may be progressing at a very slow rate. At the same time, for thoracic, a curve of 50 or more with a big rotation and RVAD angle of 30 degree, it may progress. So after maturity, you may not touch these curves and just keep observing yearly, or you can just convince ki come 2 yearly or 3 yearly. That's fine. That's possible. So after maturity also, you may have to give decisions like this to the patients when they present to your OPD. But at the same time, you have to remember the red flags of the scoliosis, that is atypical curve pattern, what we talked about. Rapid curve progression, as you see the patient curve progressing at a time within a time span interval of 3 months, 3 months, 6 months, or 1 year. Sudden, you have to identify those things. Painful scoliosis is never painful, and if it is painful, you have to look around. Abnormal neurology is always a bigger thing to be investigated before further planning is done. So, clinical presentation of degenerative scoliosis and imbalance would be just few slides to add to, and they can be a degenerative back pain or a claudication or a radicular pain, and increasing deformity itself can be a presentation. This is completely different than the other sorts of scoliosis, and these are the radiological parameters which are usually considered, like the sacral slope here, which is the slope of the upper end plate of the sacrum, which S1, which makes with the horizontal. At the same time, the point mid of the upper end plate, when drawn with the head of the femur center, the vertical axis, when you measure that angle, this is called the pelvic tilt, and the sacral slope and pelvic tilt is added together to make this pelvic incidence. And there is a central dogma of the sagittal plane deformities is that your lumbar lordosis and pelvic incidence are in tandem and working. And this is the main thing which everybody is trying to achieve and maintain that relationship. At the same time, with the age, as decompensations and compensations slowly occur in the body, something like this is the cone of your body. Like anything which in this economic cone is usually managed by the body even with compensations, but the moment you are outside this cone, it becomes decompensated, and these decompensations are frequently noted in disorders like ankylosing spondylitis or in degenerative scoliosis. So therein where you need to treat them differently than a routine decompression or a single level TLIF. You may have to do a multi-level treatment, and the aim, whatever it may be directed to, there are n number of theories for it, and what is aimed at is that this is what you are aiming for. The sagittal vertical axis should fall within 47 millimeter of the posterior corner of the superior end plate of S1. So that is posterior corner of the superior end plate of S1, and the difference between the pelvic incidence and the lumbar lordosis should be attempted to be brought less than 10. At the same time, the PT to PI ratio should be kept to less than 42. So this is what you aim up, and you are very difficult to achieve these aims, and the jury is still not out in this group of disorders. And just to add to, the coronal imbalance leading to failures are less in degenerative lumbar spinal disorders. At the same time, this sagittal imbalances leads to lot of failures, implant failures, and redo surgeries in degenerative scoliotic disorders. So this you have to understand, and you have to convince the patients for lifestyle modifications and do all what is possible to make that life, their life stable and the disability acceptable. Neuromuscular scoliosis is a different thing which is there, and when general care is affected or sitting is affected, completely tilting, and the curve is increasing in progression, you may need to keep that straightened out to preserve the function, pulmonary functions, and the vital functions. So natural history is usually favorable if you have identified the curve type, and that is what is the problem in 15 to 20% of cases, or even more than that. The predictability is not there, and the patients come to us in a bad form. So this can be completely prevented if the first day consultations of the experts in the field should be taken, and nobody should keep this group of patients to them. At least take an opinion from the spine surgeon in your region, and then keep on managing these patients at your level once it has been classified that what is to be done, because we should not miss out and create catastrophic problems which are difficult to treat. And the historical treatment, we all know this has been the historical treatments, and all is now completely obsolete things. At the same time, conservative treatment does have a role in it, And when you have identified the bad prognosticator curves and you are monitoring them frequently, or those who you know that they are going to be safer curves, those all can be managed into conservative groups. Plaster of Paris reduction curves, reduction of the curves and plaster of Paris can be given in many of the young infantile scoliosis. But climate is a very big factor. We have given number of plasters. I have given nearly 10 plasters in my life, and all of them they refuse to keep in. So in our climate, it is very difficult to make people understand and do that. So bracing is more applicable in Indian setups. The same way for adolescent scoliosis, and you can give braces, Milwaukee, Boston. You can have custom-made braces, which is there, which just gives certain amount of support and initial curves. It can be managed with this. Those who are not aggressive, and mind you, the curve arrest is dependent upon the type pattern of the curve. At the same time, the enforcement, that is the brace time of the patient, needs to be 16 to 18 hours a day. You cannot expect an outcome by a comfort zone bracing wherein the patient wears or removes at their ease. So and that is a problem with our patients, where we are not able to enforce and the patient are not educated, neither their family, to follow these things. But this does have a role. Physiotherapy definitely help in all types of uh, disorders of spine in the preventive form, as well as for balancing the things, and it is to be done when you are waiting for the final answer of the curve. Surgical intervention, as I talked, cosmesis is the main indication, and 40-degree and more may lead you towards surgery if it has become cosmetically apparent. And a higher speed of growth which you have noticed in progressive x-rays and demonstrated may need again an intervention. Neurological affection intervention is automatically invited, but when to operate this group of patients is usually after a period of 8 years, is what is the general recommendations for most of the patients, so that your truncal growth has been achieved already. But at the same time, there are certain curves, certain hemivertebras, and at the same time the unsegmented bars where you wait and you have big problems. So you have to operate early, knowing that early operation will lead to more and more surgeries also. But there are certain conditions where the answer is not out. So in those cases, you may have to intervene and wait and watch and keep doing the patient's surgeries repeated also. So usual surgeries are after 8 years, but many cases you need to intervene between 3 to 8 years, and usually before 3 years you don't intervene. The goals are to arrest the progress of the scoliosis or kyphosis, and cosmesis is the most important thing, what is the goal of many of the girls who come. And decompression, detethering whenever they are needed is to be added to it. A case what I'll just talk about, a 80-degree curve which is there pre-operative corrected to say the post-op correction was to a 22-degree curve. This is a very good correction for me, and my aim was never to correct it to 100-degree, because my aim is not to make the spine completely straight. My aim is to balance out the head, bring it over the pelvis, correct the compensation. My making the curve to 0-degree would even make this patient completely tilted to the opposite side. So that is what you have to understand. The goal is not curve correction, approximate corrections, optimum corrections, which gives a balance to the patient. What is needed is the aim of the surgery. Like this is a kyphosis, this is a 90-degree curve of kyphosis which is there. The patient presented with myelopathy, and I ended up doing a VCR with correction, and the patient responded very well. Now the patient is, now this is already 8 years, and this is a 4-year follow-up which was there. The patient is already married now. So this group of patients, you can have good outcomes. But at the same time, this patient presented quite late to me. This can be handled early, and this is possible. Surgery is risky. Yes or no? Yes, there are certain risks involved, but uh, you have to take care of the all possible technological advancement and involve everything what is possible to make it safe. And the risk benefit ratio is always a benefit to the patient and the benefit to the society. It is a very rarity that you end up giving a deficit or a paraplegia to the patients of these sorts. Yes, definitely high-end kyphosis can invite trouble. So there is a risk-benefit ratio, and with technology, what we have like intraoperative neuromonitoring is mandatory for any scoliosis or kyphosis surgery. What we do at our place, and that should be a dictum. Outside world, it is compulsory. We are using in every case, so that should be mandatory intraoperative neuromonitoring, wherein you are able to judge any neurological ensuing deficit or a developing deficit and can take necessary actions. Misonix is another tool, which is a bone cutting tool, which helps me do many of the osteotomies and speeden up the surgery significantly. So that is very much important thing. This is another case which is a rare case of a syndromic case. Say you see this patient came with kyphosis and scoliosis lumbar. There is hardly any bone which you are able to see this. These are complete shells, even osteoporotic than what you usually see in your elderly patients. So this is vanishing bone disease. You see in the MRI, this is lymph. This is all fluid which is inside. So this bones don't hold. This was complete syndromic wherein we spanned the fixation. This is a bridge fixation from above to the lower lumbar spine and pelvis. And I have harvested bone graft from the iliac crest of both sides of her father and put it on the posterior onlay graft and expected for a fusion, but this may not behave the way I want to. This is what is the immediate post-operative image which is there. The patient is doing wonderfully clinically and radiologically, and this is now 2.5 years post-op, and this is the patient is on sirolimus. It is anti-immune therapy which is there and which is needed for controlling this Graham's disease. So these are syndromic things which can occur, and CT scan say O-arm navigated surgeries is what has made many a thing more comfortable and safe for us. Like this is a 19-year-old AIS, adolescent idiopathic scoliosis, wherein this is the patient came for cosmetic concern, and these are the side bending films and the traction films, and we ended up deciding for a limited fusion in this patient. Did a navigated surgery in this. Say this is a very small pedicle to have a routine screw, and this is what we navigated the screw through. So it's so small a pedicle which is there. So this helps us to navigate, have correct placement of the screws, and after the surgery has been done, this is screw placements, and after the surgery has been done, we have a correction which is there, and we have images which are acquired per operative. We stitch those images, and we can do this all on the O-arm. So in the per operative decision itself, I can make the corrections whatever need to be managed. Say I have balanced the shoulder or not, everything is on shoulder and aligned or not. This is a 1.5 year follow-up which is there, and the patient is doing excellently well. Complications also can occur, and supramajor surgical mishaps can occur, but they are very rare, but we must be aware. Injuries can occur, lung, organ injuries. At the same time, neurological deficits can occur, especially for kyphotic surgeries. Abnormal neurologically presented patients can have more deficits, but this all has been nearly brought to zero by intraoperative neuro monitoring, which is a standard of care, and we follow it's the way. Infection can occur. Rarely ever these patients get infected at our place. Pseudoarthrosis and implant failures are noted, especially for vertebral column resections and syndromic cases, neurofibromatosis, etc. Decompensations, whatever you have fixed, after that fixation, you can see imbalances in the coronal or sagittal. Those are decompensations. Add-on curves. There can be curve add in the form of a kyphosis or scoliosis outside the construct. So these are add-ons which can occur. Mismatched expectations is what is needed to be understood. Say why we are doing that surgery, not to correct the curve to the 100%, but to bring it to an arrest and cosmetically appealing. So this should be very much made clear and safely. That is what is more important. There are other sorts of many deformities which is there, like the wet tuberculosis with kyphosis, fresh or late traumatic deformities, post-tubercular kyphosis, which is a late presentation, and severe kyphosis, neurofibromatosis kyphosis, rare syndromes, ankylosing, Scheuermann, C1C2 instabilities, basilar imagination. This also all are coming into this deformity spectrum and all have different sorts of treatments. But nutshell is that early diagnosis is needed for most of the deformities which is brought to your notice, and a watchful neglect or conservative treatment may work for 70 to 80% of cases, but 20 to 30% of cases may need aggressive early treatment, which may be have to be initiated or even be operated within 3 to 8 years of period early in many of the cases. And predictable safe spine surgery is possible almost always cases in almost always all cases. But degenerative scoliosis is a whole different spectrum of disorder wherein wherein multiple surgeries can ensue, looking to the progressive way of that deformity. Thank you very much. Hope this gives you some idea about decision making in the.
Good evening. I welcome all viewers to this webinar series. I am Dr. Shivanand Mai from Stavya Spine team. Today I am going to speak on epidemiology of this ankylosing spondylitis. So as all of you know that a healthy spine will be having its S-shaped curve with vertebrae and normal disc space maintained, which are elastic or flexible. But what happens in ankylosing spondylitis is mainly we get this S-shaped curve becomes C-shaped curve because of inflammation at the intervertebral discal level and fusion of the disc faces, restricting all the movements of the spine. The other names for this ankylosing spondylitis is Best-Steve disease or Marie-Stempel disease. So ankylosing spondylitis can be defined as a chronic inflammatory disease which is mainly characterized by pain and progressive stiffness of the spine, which results in rigid bamboo-like spine with dorsal kyphosis. So this ankylosis also limits the movements of the hip joint and even the chest movements, costochondral joints. In epidemiology, it starts mainly in second and third decade of life. So male to female ratio is 3:1, and mainly the prevalence in Europeans is about 0.5%. Our Indian prevalence we will see in next slides. And it is also being seen that in HLA-B27 positive patients, it starts 5 years earlier than those who are negative. A study from North India says that in India the male to female ratio is around 5:1, and the diagnosis of this disease in males was about 23.6% and in females was around 32.5%. This study reported the prevalence of ankylosing spondylitis in Asia, different countries. In India, we can see that prevalence is around 6 to 8% as reported by this study in 2014. Coming to the world scenario, it is the highest prevalence is seen among the white people, American, and less common in American blacks and rare among the Japanese. But Chinese are also affected. So Indian data is unavailable, but in India the prevalence ranges in between these countries. So coming to the etiology, it is the HLA-B27, that is the class 1 antigen of MHC, major histocompatibility complex, which is strongly associated with this ankylosing spondylitis. And a study by Malavia et al. In India has reported that HLA-B27 and its subtypes have been reported from India, and frequency of this HLA-B27 in the Indian population is around 6%, and in ankylosing spondylitis patient, it is seen in more than 90% of the patients. It has been seen that the monozygotic twins have a 63% concordance rate of occurrence of ankylosing spondylitis, which are genetically identical, as compared with the dizygotic twins, that is genetically distinct half and half identical. It is seen in only 24%. This shows that the cause of ankylosing spondylitis is polygenic. So with this background, we will proceed further for the clinical features, diagnosis and treatment options of the ankylosing spondylitis. Thank you for your attention.
Very good evening. Myself, Dr. Devanand from Stavya Spine Hospital and Research Institute. I'm going to take you further through the clinical symptoms and signs and a few aspects of radiology in ankylosing spondylitis. The symptoms are like this. These patients have insidious onset of back pain, usually increasing with cough, sneezing, and twisting of the back. They have severe back pain even in the nights, disturbing the sleep. Early morning stiffness of more than 30 minutes is a characteristic feature of this ankylosing spondylitis pain, which gradually decreases with activity. They also have buttock pain, usually right or left on one side, and they have good response to NSAIDs. Few aspects about how to differentiate this pain from the mechanical back pain. As you have seen the symptoms of ankylosing spondylitis, in contrast, mechanical back pain can be present at any age, usually acute in onset. Nocturnal pain is not so common, and early morning stiffness is usually less than 30 minutes, and this pain, it increases with activity when compared to ankylosing spondylitis pain, which decreases with activity. In the same way, these patients may have buttock pain or may not have, and response to NSAIDs is usually variable. Once it comes to the clinical signs, most of these patients have loss of normal lumbar lordosis, and they have severe restriction of the spinal mobility, especially the extension of spine and the lateral flexion is usually restricted in the early stages. You can see this patient in his early 30s who has affection of the ankylosing spondylitis. The gait, you can see that he has short steps, drooping forwards. His neck movements are restricted, and he usually gets tired by walking few steps. So these patients have associated hip arthritis also. So what test do you do? If you start examining the patient from lumbar, thoracic and cervical spine, lumbar spine usually we do modified Schober's test. We usually mark 2 points and then we ask the patient to bend forwards. Normally the movement is more than 5 centimeters, whereas in these patients it is restricted in flexion as well as extension. In the thoracic spine, you know that they have less of chest expansion. This is because of costovertebral and costotransverse joint ankylosis, and the movements are usually restricted to less than 2 to 2.5 centimeters. In the cervical spine, when you ask a patient to stand onto a wall, usually his neck cannot touch the back of the wall, and you can measure the distance from the wall to the occiput. In the same way, the chin-brow vertical angle as seen in this image usually is more than 25 to 30 degrees in these cases in the advanced stages. Apart from back pain, these patients also have joint pains, stiffness and swelling in small different joints. Hips are the main joints which are usually affected in the peripheral joints, and shoulders in few cases. 30 to 40% of the cases, they come with acute anterior uveitis presenting as red eye, which is painful. And few cases have inflammatory bowel diseases, cardiac abnormalities like aortic regurgitation, and also involvement of lung and pulmonary fibrosis. So what X-rays we usually advise in these patients? Usually we advise X-ray pelvis, including both hip joints, AP view. On this, we have SI joint arthritis, which is usually classified into 4 grades. Grade 1 is when there is a mild irregularity or fuzziness of the joint. but there are no erosions or sclerosis, and the joint space appears normal. When it comes to grade 2, the joint space may be increased because of fluid collection, and grade 3, the joint space usually starts reducing with the presence of erosion and sclerosis. Once it comes to grade 4, it is usually fused. In the spine, in the same way, we have this bamboo spine appearance and characteristic fusion of the ALL as well as the squaring of the vertebra. How do you differentiate the classic diffuse inflammatory skeletal hyperostosis and ankylosing spondylitis on X-ray? Dish usually has large flowing osteophytes, which are not fused usually, but once it comes to ankylosing, it is fine syndesmophytes. In ankylosing, the facets, SI joint, and the intervertebral discs are involved, which are spared in dish. The inflammatory markers are usually high, and HLA-B27 may be positive in up to 85% of the cases of ankylosing spondylitis. So after X-ray, if it is grade 1, which we may not be able to see, the gold standard would be CT scan for the structural damage detection, as you can see on the left-hand side. The CT shows bilateral ill-defined cortical margins and subcortical erosions. In the MRI, we usually go for T1 or stir images, which usually depicts this classical edema and sclerosis. So for the MRI scan, the bone marrow edema is usually better appreciated in the stir sequences. T1 weighted sequences for the post-inflammatory changes, especially erosion, sclerosis, and ankylosis. Gradient echo sequence is available in only few MRI centers, which differentiates the changes between the bone and cartilage. So the classical Romanus lesions, they are seen as a shiny corner sign. They are hyperintense on T2 because of the edema and hypointense on T1. In the stir also, they have increased signals. And this is the classical MRI of ankylosing spondylitis showing the Romanus lesions. So these patients on long standing, they have few complications because of ankylosing spondylitis and the restricted movements and decreased activity. These patients, they gradually develop osteoporosis on X-ray. In the same way, when they have a small injury, when they fall from a stairs they have a fracture of this bamboo spine, classically called as Anderson's lesion, and this on MRI is usually labeled as spondylodiscitis. So these cases needs to be uh, picked up early and should not be managed with as a case of spondylodiscitis. So how are these patients managed conservatively and operatively? We are going to discuss in the further presentations. Thank you.
Good evening. I am Bharat Dave. Will be speaking on the conservative management of ankylosing spondylitis. Lot more can be discussed and taught and can be offered to the patient. I am going to share our protocols and our treatment plan, what we do at Stavir. Why the treatment of ankylosing spondylitis is so important? We have learned from the previous talks that it is a crippling disease. Patients, they have morning pain. Their mobility gets restricted as disease progresses. The lung expansion also gets reduced and it will lead to many complications. So we really need to prevent this complication and we really need to, if we can, avoid certain complications. So aim of the treatment should be basically the medication to reduce inflammation, but this suppresses the immunity. We really need to aim for physical exercise, physical activity. Medications, they are must because they reduce the inflammation, and physical therapy and exercise, they certainly help us in keeping the movement and lung capacity at its optimum. So that should be the aim, inflammation reduction and keeping the mobility and the lung expansion as much as we can. How do we manage all this? Well, we have three options in the management. One is the medical option, medical management. Second is the most important is the physiotherapy or the activities, and the surgical when required. And that will be discussed by our eminent speaker from overseas, Dr. Dilip Sen Gupta. Medical management includes non-steroidal anti-inflammatory drugs, and that usually is the first line of management, but we should consider the long-term efficacy and the side effects. At our center, we usually start with 90 milligram of itrocoxib, and then we taper it down and we advise the patient to take it on SOS base. But that is to initially reduce the inflammation and to give the confidence in the treatment. Occasionally, people give the indomethacin, Indocap, and we have found at our center, many of them, they have the gastric upset. Other medication that we use at severe is sulfasalazine. Sulfasalazine reduces the inflammation, and long-term usage, we have found it quite uh, important and without major side effects. Methotrexate and hydroxyquinone can be added either in the form of oral tablet methotrexate or injection. We usually give once a week, 10 milligram dose, and we really need to monitor the side effects of methotrexate by doing regular blood test. Newer medicines like TNF blockers, etanercept, infliximab, and there are few more, seclutamide, all these things, they certainly help in stopping the disease activity by decreasing the inflammation and improve the spinal mobility. But it is not without side effect because it suppresses the immunity as well. And there are fixed standard protocols which we follow in the form of all the patients should undergo the tuberculin test and the liver enzyme test and the routine blood test as well. And they have to be monitored because most of these patients, they develop the immunity issues. We had one patient recently who developed the tuberculosis pulmonary, which was reactivated, and the test was negative. So these are the things one should keep it in mind. These medicines, they certainly have good efficacy and they are expensive. So that is to be taken care and to be discussed. 1, 14 and 45 days. These are the doses which can be given particularly for the infliximab, and this can be repeated yearly. Most important is the physiotherapy. The mobility and the lung capacity has to be the goal for the active exercise, and that can be done. The classic example which is shown here, like the bamboo spine, but then this bamboo can be molded into the chair or into the sofa if it is molded properly, and that's what we should really talk to the patient, teach the patient, and let the patient decide the further treatment plan. But we really spend time, give time to the patient and advise them what are the aims and what are the things that's going to happen. We recently have published a book which is in our Gujarati language for the patients as well. So the main aim, we really need to tell the patient that you should really have the friendship with this disease because this disease is not going to go and lung capacity will gradually reduce. The bending of the spinal column is going to occur. They all are going to go into the flexion, and hence we advise them to have the activity accordingly. The rules to follow, we advise them 20 minutes of walk and 20 minutes of deep breathing exercise. And specifically we mention that any exercise that increases your pain should not be done or should be done with caution. And we advise them at least 10 minutes in the morning, 10 minutes in the evening should be followed religiously with full discipline. We advise them not to do rotation because that rotation can lead to the fracture, microfracture into that stiff bamboo spine. Improve posture, improve mobility, improve muscle strength, and at the less expenditure, we try to get the maximum. That should be the goal. Certain stretching exercise has to be done religiously. Other joints, we really should keep them mobile in the form of hip, knee, shoulder. The bigger joints, they also get affected. So we advise them to do the cycling and to do mainly the walking. The deep breathing, as we know, that the ribs they move up and down and side by side. So both this really helps because this is going to become zero as the disease progresses. So we tell the patient that you should really develop the friendship. And how do we develop that? Suppose patient has complete neck movement, zero neck movement, stiffness. Then we advise them to keep the straw into their pocket. So they will be able to drink the whole glass of the water. Otherwise, they will not be able to drink the whole glass of the water. And this is a small little thing, but small little tip will certainly make life easy. Similarly, in the household things, they're like switchboard. If they are not able to reach, they should be redesigned and replanted and relocated. So small things like, chair, sitting, sofa, bed, all this can be monitored accordingly and should be tightened accordingly. Particularly bed and the pillows, because most of them they will have the kyphotic deformity, so they may need 2-3 pillows and they may not have full extension of the hip as well, rather than neutral, so they may need pillow under the knee. So these small tips they should be discussed, and these things should be planned in day-to-day activity. Stoop posture, because the stoop posture is going to occur, practically it is inevitable. So if we ask the patient to stand next to the wall, try to remain erect as much as they can, but without pain. This is very important, because if we advise them to do it religiously, they may do it and they may have the fracture, microfracture, and Anderson lesion. So that is to be avoided as well. Can easily be avoided if this is shared, not up to, they can stand next to the wall, but up to the pain. So in summary, regular exercise in the form of deep breathing, pranayam, and brisk walk. This will keep them mobility. Avoid smoking and alcohol. Many of these patients, they get habit of taking alcohol because that will tame their pain down. So that is to be taught, discussed, and to avoid, because that will lead to fall as well if they take alcohol. Overdose of the alcohol. Medicines like NSAID plus the DMRD, this is modifying drugs, should be used in the initial stage of the disease, and this should be discussed. We always stress on the regular follow-up, because we advise the patient to take medicine for long, and if side effects they happen because of the drug or the disease which is progressing very fast, then we advise them accordingly. And surgery for the fracture and deformity like Anderson lesion and deformity like what's been shown in the first slide, the flex deformity, that can be treated by the surgical treatment, and that will be discussed in the next talk by Dr. Dilip Sen Gupta. Thank you for your patience hearing. Thank you.
Surgical treatment in ankylosing spondylitis are usually indicated for treating fractures or deformity. Fractures in ankylosed spine is very different from fracture in a normal flexible spine because spine is fused into one bone like femur, and fracture tends to displace very quickly and in a large way, leading to neurological deficit. Here is an example: a barely displaced C4 fracture displaces easily as the head goes into extension, and particularly after intubation at surgery, where the head needed to be flexed to recreate the flexion deformity in order to close the fracture gap and then fix the fracture in front and back. In most cases, however, when the fracture is recognized, an in situ posterior fixation alone may be adequate. The fracture tend to displace quickly and leading to neurologic deficit, which could be 50% or higher in cervical spine fracture. The thoracic spine fractures do also displace as the kyphotic spine goes into hyperextension through the fracture line, but the neurological deficit is little less frequent, maybe under 50%. Often the patient may be very large, like in this patient, where you can see the gap between the head and the headboard, and that's because of the ankylosing spine. But with the weight of the head, fracture tend to open up in front, fortunately without causing paralysis. And we had to fix the fracture quickly, even in a person who is extremely large, an obese person. Carefully recreating this kyphosis of the spine and then fixing in situ and using additional rods or 4 rods instead of 2 rods to stabilize the fracture to prevent hardware failure. We are lucky here to see the patient is up and about walking. The other kind of fracture in ankylosing spondylitis are called Anderson lesion, which is essentially a spondylodiscitis mimicking an infective or inflammatory lesion. In this article, the Korean authors mentions that there are essentially two different kinds of lesions. One is without trauma, and there is only inflammation of the disc and adjoining end plates, mimicking infection. And in these cases, that may not need surgery, and stabilization and anti-inflammatory medication can lead to a solid bony fusion. More frequently, however, it starts with an undisplaced fracture, which rapidly goes into non-union and progressive deformity and may lead to even spinal cord damage. And the treatment is a quick recognition and stabilization with or without anterior column reconstruction. The deformity is a very different and more frequent indication for surgery. Extreme deformity of this nature are much rare in our country, but more frequently seen in China, Korea, etc. The deformities are essentially of two different ballgame here in thoracic and lumbar spine kyphosis, leading to mostly sagittal balance problem, and cervicothoracic kyphosis, leading to mostly visual angle problem. If the cervical spine is flexible, the patient tend to hyperextend the cervical spine to achieve a forward gauge, and their primary problem is to look forward, and they tend to bend their knees to relax the neck to be able to see in front. Here, the gentleman, after correction of the thoracolumbar deformity, and has an acceptable gaze angle despite incomplete correction. The compensation of the gaze angle and the sagittal imbalance is done by flexion of the knees and extension of the hip. To uncover the true magnitude of deformity, one has to ask the patient to stand against a wall and then measure the chin-brow angle to see the visual angle correction needed and occiput to wall distance. The correction is done essentially by spinal osteotomy. The first one was described by Smith-Peterson back in 1945, which essentially involved posterior column resection through the lamina and facet joints and breaking through the anterior column by opening up the anterior column without doing any osteotomy through the vertebral body. The disadvantage of this procedure is that you have got no control where the anterior opening will happen, and it can even cause catastrophic complication like rupture of the anterior blood vessels. These are rarely done in these days, but in this case, we had to do it accidentally. Like after the osteotomy, as we closed the osteotomy gap, it opened up in front inadvertently, risking the disruption of blood vessel, which fortunately did not happen. But we had to quickly take the patient back to operating room with additional fixation and bone grafting to get an acceptable result. More commonly these days, we do posterior closing wedge osteotomy, and the wedge goes all the way to vertebral body and not just the posterior column alone. This is typically called pedicle subtraction osteotomy. And here is a typical example where the pedicle is taken away and the foramen of two adjacent segments become into one foramen. The alternative is to do multiple segment osteotomy through the facet joints and getting a small correction without taking the osteotomy into anterior column. And this gives about 10 degrees of correction at each segment. And when you do at multiple segment, the sum total could be adequate. This gives a much more harmonious correction, and often it is called posterior or polysegmental wedge osteotomy. And these days it is also called as SPO, which is very different from large single level anterior opening osteotomy described by Smith-Peterson originally. This is an example of a harmonious correction. There are places for both SPO and PSO to do in combination, as I will describe later. Here is an example where the predominant deformity is in the thoracolumbar spine, and we found that if we do an osteotomy at L3 level of this magnitude, we can get a good correction, and according to plan, we did the surgery. It is important to position the patient at the bend of the table so that at the end of the osteotomy, we can unbend the table and close the osteotomy gap, and close the fixation with a decent correction. Where the deformity is not focal and is more generalized, it may be more important or better rationale to do multiple segment wedge osteotomy rather than single large osteotomy. Like in here, we did osteotomy at multiple segment, and then the closure of the osteotomy gives a much more harmonious correction, as you can see here. If you do pedicle subtraction osteotomy with a single segment of large correction, maybe 40 degrees, there is a problem. Like in this patient, we had a problem where the closure of the osteotomy led to buckling of the dural sac, and we are afraid that the spinal cord may also buckle and leading to paralysis. So we ended up accepting an undercorrection. To avoid this problem, Thomason described closing opening wedge osteotomy, what essentially means that in a normal osteotomy, the angle of correction is done through the anterior edge of the vertebral body. Instead of doing that, if the fulcrum is at the level of the spinal cord, then closing the posterior column will open up the anterior column and needing anterior reconstruction. Here is an example. This lady had a large focal kyphotic angle, and we opened it up, did an osteotomy, and to prevent buckling of the spinal cord, we opened up the anterior column by an anterior reconstruction and posterior stabilization, and this is the end result. The planning of osteotomy, at what level and what kind of osteotomy, is important. To plan, one has to understand the effect of osteotomy. If you do an osteotomy in lumbar spine, the angle of osteotomy will always be same as the angle of gaze angle correction, unless the cervical spine is also flexible. If you make the osteotomy at a lower level, the same angle of osteotomy will cause a greater correction of the sagittal balance, but the visual angle correction will remain the same. If you do the osteotomy at a higher level, to get the same amount of sagittal balance correction, you will need a bigger angle of osteotomy, and that can cause a bigger and undesirable overcorrection of the gaze angle, as we will see in another patient soon. Here is a patient who has both sagittal balance loss of 13 centimeter and 45 degrees of visual angle correction needed. We found that if we do an osteotomy at this level, we can correct with a 20 degrees of osteotomy, very easily doable, and can correct the sagittal balance almost adequately, but the visual angle remain undercorrected of 25 degree. And to do that 25 degree of visual angle correction, 2 or 3 level of small osteotomies in the thoracic spine will not affect the sagittal balance as much, but will correct the visual angle appropriately. Like in this example, here is the sagittal balance loss and visual angle correction needed, and we did the planning that this amount of correction will correct the incomplete correction of visual angle, but complete correction of the sagittal balance. And at that stage, we did the lumbar correction and then added some polysegmental wedge osteotomy in thoracic spine to adequately correct the visual angle. This is clinical outcome. Over and under correction are the biggest pitfall of deformity planning. Under correction is more common. Like in this case, we had to do another surgery to correct the sagittal balance adequately. Overcorrection, in particular in the cervical spine, is more of a problem. In this lady who had in 1984 had a large angular correction at the lumbar spine, but developed further worsening of the upper thoracic kyphotic deformity, leading to loss of visual angle. And we were enthusiastic to do osteotomy in the thoracic spine, and that corrected the sagittal balance well, but overcorrected the visual angle. And in this patient had an unacceptable problem that she could not see what is lying in front of her feet. So we had to do a reverse osteotomy of the cervical spine, or extension osteotomy of this, flexion osteotomy of cervical spine to get an acceptable gauge angle. Cervical thoracic deformity is very different ballgame, where the visual angle correction is predominantly affected and osteotomy is much more hazardous. It is usually done at cervicothoracic junction between C7-T1 where the canal is widest, brachial plexus is spared, and vertebral artery enters above the level of osteotomy. This is a book chapter that I contributed to that explains that the cervicothoracic junction correction is important to position the head and planning the osteotomy and the hardware positioning, then make the holes for the hardware, do the posterior column resection, apply the hardware before osteotomy, then as you close the osteotomy, then complete with the hardware on both sides. This is a clinical example. More recently, Frank Schwab classified osteotomy into 6 grades, of which grade 1 and 2 is what we described as polysegmental wedge osteotomy. Grade 3 and 4 more representative of classic pedicle subtraction osteotomy, and grade 5 and 6 are anterior opening posterior closing osteotomy that requires anterior column resection. In summary, I can conclude that deformity correction in ankylosing spondylitis is a risky surgery, but it is one of the most rewarding surgery that we can do. Thank you very much for your patient hearing.
Thank you, sir, for an elaborate talk. I would now like to summarize and highlight the key takeaway points from today's talk. Regarding spine deformities, Ajay sir has clearly explained how early diagnosis is the key to the treatment. Timely treatment initiated can drastically change the outcome that we get in spine deformities. This is where our school screening program helps. There are cutaneous markers of spinal dysraphism like the tuft of hair or the trophic ulcers, which the primary caregivers, the primary physicians, or the general practitioners, everyone can identify and must raise an alarm for further investigation in these cases. There are some red flags or warning signs in deformities, particularly those seen in kyphosis cases, which is progressive neurodeficit, bowel bladder involvement, rapid progression of deformity, which should initiate immediate investigation and would require an urgent treatment. Similarly, painful scoliosis in idiopathic scoliosis is not painful, so pain along with scoliosis should raise suspicion of something else going on there and must be investigated. Treatment of spine deformities is very much possible. With timely and adequate treatment, expected outcomes can be achieved. However, those presenting with neurological deficit will need careful counseling so as to have realistic expectations. Coming to ankylosing spondylitis, as we have seen, it is a type of arthritis which mainly affects the joints of the spine, and it is commonly seen in young populations, particularly patients present with back pain and early morning stiffness. So this history of early morning stiffness should be specifically asked about, and sacroiliac joint involvement is seen early in the disease. Hence, whenever we order an MRI for a young patient with back pain, we must include MRI and screening of the sacroiliac joint. In this case also, timely diagnosis and treatment is the key, as it can prevent progression of disease and drastically limit the disability. Now with the adjuvants like biologics that we have available, we can actually cure many of the patients and significantly decrease the disability that the disease causes, and these kind of grotesque deformities should become a thing of the past. Another thing which was highlighted in the talks is for patients of ankylosing spondylitis, it is absolutely essential to keep all the joints mobile. Hence, regular physical exercises is a must for these patients. If the patient's condition allows, swimming is a very good exercise. Similarly, lifestyle modification, that is modify your home environment, the transport, the car, or even the bathroom. As we see here, handrails can be installed in bathrooms to prevent falls, because we know the bones are brittle in this disease and any small injury can cause major fractures. Thank you. Before we start our question and answer session, I have an announcement to make. Today's guest speaker, Dr. Sen Gupta sir, has expressed his eagerness to help patients in India. Sir is now available for telemedicine consultation through this website, centerspine.in. So when we go to this website, centerspine.in, this is the homepage which gets displayed, and there is an option for book an appointment. If we click on book an appointment, this is the page that gets displayed, which shows the preferred method to be through HealthPlix application. The method to be followed has been explained on this page. The other options available are through WhatsApp as well as through email. So those of your patients who wish to consult Dr. Sen Gupta sir can be guided to this website, centerspine.in. I'm sure our patients will be happy to take the benefit of this opportunity. Question and answer session. And the first question is for Dr. Ajay Krishnan sir. Sir, how effective is bracing for congenital scoliosis? And there is another question which is related. How do you ensure patient compliance with the brace? Ajay sir?
I think you can
Okay.
ask.
Okay. I'll take up another question, which is for Shivanand sir. Sir, what is non-radiographic spondyloarthropathy? That is what one of our doctor wants to know.
Yeah, thank you for the question. So non-radiographic arthropathy is the entity where the radiographs will be normal. Patients does have symptoms and it is diagnosed on MRI. MRI shows there is some inflammation mainly at the SI joint, hip joint. So because of this non-radiographic arthritis, the diagnosis of this spondyloarthritis has increased and it is diagnosed on MRI scan, and mainly it is more commonly seen in female patients. Thank you.
So that is why it is essential to take screening MRI. Otherwise, we will miss
MRI,
this.
yeah. Yes.
Thank you. Another question for Dr. Shivanand sir. Is it a lifelong disease? The doctor is asking about ankylosing spondylitis. Is it a lifelong disease or can it be cured if diagnosed early?
Yeah, thank you. Yes, definitely it cannot be cured completely, but the inflammatory process which goes in the body system can be controlled. The progression can be controlled earlier with this biological treatment and interferon therapy. Earlier the best. Once the joint fuses, the treatment will not be effective. Thank you.
Okay, there is one question from doctor in Rajasthan. He says in his area, he sees a lot of fluorosis patients and he wants to know how to differentiate fluorosis from ankylosing spondylitis. Dr. Devanand sir, if you can answer this.
Yes. As I have mentioned in my presentation, we can differentiate three conditions. Diffuse idiopathic high skeletal hyperostosis, second is ankylosing spondylitis, and third is fluorosis. The main differentiating factors between ankylosing spondylitis and fluorosis is clinical as well as radiological. Most of the patients in ankylosing spondylitis have morning stiffness for more than 30 minutes, and they're usually young male patients, whereas fluorosis can affect anyone. On radiology, if you see, fluorosis usually has different features like density of the bone is more when compared to ankylosing spondylitis, where it is vice versa, either osteoporosis or normal bones. And ankylosing spondylitis has squaring of the vertebrae, where you can call it as bamboo spines. Whereas in fluorosis, it is usually dense vertebrae with normal shape of the vertebrae. So these are few features. And the main X-ray which you need to take is X-ray of pelvis, where in fluorosis, the SI joint is usually spared, but in ankylosing spondylitis, the SI joint is usually starts the stages like stage 1, 2, 3, and fusion of SI joint, what I have mentioned. Thank you.
Thank you. To add to that, we'll see mottling of the teeth in fluorosis, which again help us. I think Ajay sir is with us now. Sir, can I put up the question for you? Hello, Dr. Ajay sir.
Hello.
Yes.
Hello.
Sir.
Yeah, I'm here.
Yeah, so the question for you is how effective is bracing for congenital scoliosis and how do you ensure patient compliance with bracing?
I did talk about that. Bracing is definitely helpful. It doesn't help in correction, but it definitely stalls somewhat the secondary curves getting more prominent. That is one thing. But to ensure that the person is wearing a brace for 16-18 hours, it's a very difficult task in the hands of parents who usually give in to the patient, the kids' demand. So in Indian setups where the climate is temperate, it is very difficult to achieve those things. And I have not seen anybody who till now who is enforcing to say 16 hours of 18 hours of brace time. Yes, when you are waiting, you have to give something, and people do take up. So by education level, you can see it is very nicely followed outside India, wherever scoliosis clinics have been visited. They enforce it, people follow it religiously, they don't feel bad about it. Here they have all excuses to make and people don't follow. Secondly, to get a good brace in our setups also is a big problem.
Challenge.
And yeah, that also is a problem because people don't get good braces. There are less makers of good braces, and these braces need to be readjusted on and off. At least a 6 months to 1 year it needs to be reassessed, and during the growth spurts it needs to be readjusted further. So that all adds to the cost, and people usually don't follow it. That has been our experience in these many years.
Thank you, sir. There's another question for you. Can untreated scoliosis be the cause of back pain in young adults?
No, absolutely no. The incidence of backache goes to the region of 60 to 80% of normal people have backache without scoliosis even in their lifetime. And they are all considered as benign backaches. The same way, a scoliosis patient also comes in the normal category of the people wherein you have backache for no reason. So reason because of poor postures, lack of exercises, not doing adequate care of the back, poor ergonomics. This all add to the backache. But per se, it is a actually you. This is just a coincidence that you have a scoliosis and you have pain. Painful scoliosis is a different thing, and scoliosis having pain is different thing.
So this is a question for Dr. Devanand, sir. What would be your advice regarding activities of daily living like walking and swimming? Should it be restricted for patients with ankylosing spondylitis?
That's a good question. The activities of daily living of ankylosing spondylitis patients usually are restricted because of their morning stiffness as well as pain. But we need to keep moving. So the exercises should be limited to passive exercises, not the active stretching exercises, which usually put a lot of stress on the bones. In the same way, the home environment should be modified in such a way, especially in elderly patients, that they usually do not slip or fall and have a fracture. Or even if they want to climb stairs, they need to have that railing, and even in the bathrooms. And swimming usually is in the younger patients, but not usually advised for the older patients, where they have a risk of, not giving a lot of chest expansion and difficulty in swimming. But yes, young patient, it helps.
There's a question from Dr. Shah from Wired for Bharat Dave, sir. He wants to know what is the dose and duration of sulfasalazine to be administered for ankylosing spondylitis.
We usually give sulfasalazine at least for 2 years, 500 milligram twice a day. We keep monitoring the response and then we keep modifying the dose accordingly. But most of the time we advise the patient to continue, have the regular follow-up. If patient stops responding, then we may switch over, but we certainly advise them to continue and regular follow-up is must. So we advise them to continue at least for 2 years.
And the question for you is for ankylosing spondylitis patient, what precaution needs to be taken while getting MRI?
That is, I think, very important question. We have had couple of episodes where patients were given anesthesia so that they can go into the gantry, they can enter into the gantry because they have the fixed flex posture. That should never be done because that will lead to the fracture and patient will wake up if the anesthesia is given with the paraplegia or quadriplegia. And we have had couple of incidences where the anesthesia was given in order to accommodate patient into the gantry. I'm repeating the same sentence again because we really want everyone to know not to give anesthesia to ankylosing patients for MRI. That is one. Second thing, MRI can be done with the coil put on the side. So they can lie down on the side and the coil can be put on the side. There are coils available. The images may not be as good, but at least it will give us fair idea about the compression and about the anatomy as well. So these two things has to be really learned, taught, and to be implemented in day-to-day practice by all the orthopods, by all the residents, those who are treating ankylosing patients.
Okay. Next question is for Sen Gupta sir. Sir, you have seen the standard of care both in India as well as in United States. So we would like to know from you how is the approach or the treatment of these patients different in United States, or what is your approach towards these patients?
I do not think there is essentially a big difference in today's terminology as opposed to 20 years back. The only difference that I find in United States that the people do approach the doctors early. So we are fortunate to get less severe deformity to get on the operating table, as opposed to in Far East, like in China and Korea, you see the extreme form of deformities, like patient bent like a U. And even in our country with milder deformity, they will just accept the disability rather than coming to doctors until such time that they can no longer accept it. So our doctors in India has to treat much more difficult clinical problems as compared to in the Western world.
Also about the availability of biological agents, it is usually it comes early in United States than and it reaches India 2 or 3 years later. So I think that's an advantage that you people have. Sir, we would also like to particularly want you to talk about the post-op protocols that you follow at your center, whether it is
Sure.
physiotherapy or rehabilitation, or what else which you would like to highlight.
We try to mobilize the patient as soon as possible, and it is very different from every patient depending on their pre-existing disability and comorbidity and the extent of surgery they needed. And the therapists do work with the patients from before surgery so that they can establish a relationship and they can get the patient out of bed as quickly as possible. We also have the physician like the MDs or the internal medicine doctor who also take care of the people from medical management, and the PMNR doctor or physical medicine and rehab doctor. They help the physical therapists and occupation therapists to guide these people. And so it's a team approach for post-operative recovery. But the essential difference that I noted when I used to practice in India, and I still visit India frequently 2-3 times a year, that people stay in hospital for a much longer period and mobilized after surgery at a slower pace compared to in the Western world, where the hospital stay is very expensive. So we cannot afford to keep the patient for weeks after surgery. And usually within a week, they are discharged to a rehab center, but the therapy to get the patients out of bed and mobilized, it starts even before they're discharged and closely monitored in the acute rehab facility.
Okay, thank you, sir. Bharat Dave, sir, if you want to add a few points to that, and then maybe you can conclude.
I think probably in our setup, the deformity work, I think the patients do not have that crooked deformity which you have shown, because most of the patient, whatever we get in the clinic, we don't get that crooked deformities. I'm not sure why, but we certainly do not get that. That is one. Second thing, probably the disease which we have been seeing in our clinic is a lot more than what's been narrated even in the epidemiology, because we do see a lot of young patients who have sacroiliac joint positive and we treat them with their merits. Third thing, probably, our setup has got a lot of homeopathic and Ayurvedic medicines. I'm not sure what they do, but there must be some role of those medicines as well. I do not want to really highlight those things, but I'm not sure, how much the effect and influence in these condition, chronic condition as well. We in our practice certainly tell the patient for the regular follow-up, which I have mentioned in my talk. Second thing which we certainly tell about the deep breathing and pranayam, and probably walk every day 20 minutes and do regular exercise. That's what we tell as well. So these are the pulse of wisdom we really talk, and we certainly educate the patient and with the books written as well, with the patient education book which we have written on the ankylosing and osteoporosis, which we distribute to the patient in our local language. These are the things that we follow. Anything else anybody wants to highlight? I think this is what we want to really, educate all our patients, particularly young population, for the ankylosing. We certainly have used the disease modifying drugs, and certainly, it certainly stops the progression. But in an advanced case, it won't do any good to anybody. So we really need to act in the early stage as well and diagnose it early.
I fully agree with you, Bharatji. I do not like to propagate a false impression that the cases that I have presented in my presentation, they were to give an example of a particular point or a particular action or a planning for surgery, rather than they are the routine cases that we see.
Yeah.
The other point is that in our country, we get a lot of tuberculosis and infection and that kind of deformity, which are way more difficult to treat surgically than ankylosing spondylitis.
Yeah.
And third point is, the more the deformed spine in ankylosing spondylitis, it doesn't make it more difficult surgically. It is more difficult from medicine and anesthesia point of view, and to position the patient on the table point of view. But surgically, you can work from side to the anterior aspect by posterior approach, way away from the spinal cord. As long as you are not taking the posterior vertebral margin out, you can take the entire vertebral body by posterior approach to decompress. And only time you become careful that put a posterior rod before you take the posterior vertebral body, that shelled out bone out, to make the spine into two fragments. But essentially, more deformity doesn't mean more difficult surgery. Surgery becomes more extensive, but little less difficult.
Thank you, Dr. Sen Gupta, for joining us from all the way live from USA. Ravi, you can just add and just do the honors.
Thank you everyone. Thank you, Sen Gupta sir, specifically for joining us from United States. And we would like to conclude this question and answer session, and would like to announce that the next webinar would be on advances in spine surgery. Thank you so much from our end.
It has been a real pleasure. Thank you very much, all of you.
Thank you, sir.
Thank you, sir. Thank you.
Thank you so much to all our wonderful speakers for these illustrative discussions. Thank you to all the audience for joining us today for this Thursday evening. The Knowledge Karwa shall continue. These recordings are there on YouTube, and we shall also be circulating the link post the webinar to all of you. You can subscribe to Savya channel on YouTube and Facebook page for regular live updates. They have been doing a lot of patient education programs as well. Today was the 5th webinar of the series for us. The 6th webinar, as just mentioned by Dr. Ravi, is on 15th October, same time, that is 7 p.m. The topic would be advances in spine surgery. Shelcal feels immense gratitude to all of you. A warm thank you to Dr. Dilip Sen Gupta for joining us from Texas, USA. Thank you, Dr. Bharat Dave, Dr. Ajay, Dr. Devanand, Dr. Ravi Ranjan, and Dr. Shivanand. It has been such an honor. Good night to all of you, and stay safe. Thank you.
Thank you.
Thank you, madam. Thank you, everybody.
Thank you.